Great, welcome to the webinar. Before we begin, please be advised all attendees are muted. You may type your questions into the Q&A box in the toolbar located at the bottom or side of your screen. We will conduct a Q&A session at the end of the presentation. This webinar will be recorded and archived for future reference. Welcome to our webinar on advanced peripheral intravenous skills for the emergency nurse using point-of-care ultrasound for difficult access. Here with us today, we have Kristen Armstrong and Carol Stavely. Kristen is a clinical application specialist with FUJIFILM Sonosite, and she is a licensed sonographer with 20 years of experience. And Carol is the Director of Strategic Initiatives for FUJIFILM Sonosite Canada. Carol is going to monitor the Q&A session at the end and introduce our speaker, Lisa Grew, today. I'll hand it over to you, Carol.
Hi, everyone. So Lisa Grew started her career in 2006 as an emergency staff nurse at Guelph General Hospital in Guelph, Ontario, where she's now the emergency clinical educator, professional practice lead. She followed her passion for continuous learning in the clinical nurse setting and obtained a master's degree in nursing with a teaching focus in 2017. After recognizing the value of ultrasound-guided peripheral IVs in difficult access cases, Lisa led the development of ultrasound-guided PIV training program for nurses at Guelph General Hospital. Her evidence-based collaborative approach resulted in high interest and participation among ED nurses. As a result, the nurse-led ultrasound-guided PIV program has begun making a positive impact on nursing practice and patient satisfaction at her hospital. So I'm going to let Lisa tell you more about the whys and hows of nurse-led ultrasound-guided peripheral IVs for difficult access. Over to you, Lisa.
Thank you, Carol, and thank you for having me today. I was actually quite honored to be asked to speak today, especially about emergency nursing, and to speak to you about advanced skills in emergency nurses, specifically the use of point-of-care ultrasound. So some of you may have heard of ultrasound-guided IV or are currently using this technology to gain vascular access. However, I'm guessing that many of you who are emergency nurses may just be curious to know what I can offer as advanced skills for a group of nurses who are second to none when it comes to IV skills. So you might be thinking how a seasoned emergency nurse could get even at IVs. And I'm not here today to suggest that their skills are not already great. I'm simply here today to offer another tool to augment IV skills in the ED. So my role is educator. So point of care ultrasound IV has been more of a small grassroots project that I latched onto because I found it valuable. So at my hospital, we're still in the process of getting ED nurses trained on this skill. So to give you a little bit more context, about my hospital. So my hospital is in Guelph, Ontario, Canada. And we are a 187-bed hospital that serves a population of 130,000 people in Guelph, Ontario. We're a designated stroke, vascular, and bariatric center. And our ED is a 21-bed emergency department that serves approximately 60,000 visits annually. And this is climbing. So currently our average patient assignment that we see every day is about 160 to 170 people every day. So my association with point of care ultrasound began in my educator a couple of years ago when one of my ED physicians, Dr. Mary Cameron, came to me and told me about her most recent POCUS update and told me that she had learned about this new technique. So she said, you know, ultrasound guided PIV, you know, she asked me, do you think we could do this for our nurses? And she said, you know, I have IV skills, I have ultrasound skills, you have IV skills. Can we put them together and come up with some training for the nurses? So, which I answered, yes, let's do this. So my journey implementing point of care ultrasound IV has not been a sprint to the finish, but rather a persistent and devoted hike through the implementation process. I haven't arrived at my destination yet, but I'm here today to share how I got started and how I've been picking up momentum. So I just want to offer right off the bat, for those who don't know a lot about this tool. So as ER nurses, we use several tools to our advantage to gain IV access. So we use warmth, we use gravity, tourniquet sometimes, 2 tourniquets sometimes, vein finders if you have them in the department. But what point of care ultrasound provides is just another tool for specifically difficult access patients. This does require more advanced technique and skill to deliver. So just as physicians who blindly inserted central lines about a decade ago, they transitioned to using point of care ultrasound for their insertions as well. So most of our EDs have this tool that can be used in other ways too. So before we get started and talking about implementation, I'm just going to show you the whole procedure. So I'm just going to stop my screen here and we're going to do a little video.
Look back to make sure nothing has moved. If nothing has moved, then I poke ouch. Okay, now I find my needle tip just by sliding up and down. I can shake the needle a little bit to give some movement on the tissue. And the target vessel, I want to take it from a circle and make it into a heart shape. Once I have the heart shape, I can rely on IV skills and puncture quickly and then find the tip. So I'm scanning up and down with the ultrasound again, and there's the tip in the middle of the vein. I've got flashback, so I'm happy. I can just drop my angle and advance slightly and then go back to just IV skills and just thread the catheter. If I'm not sure, I can go in a long axis over the vessel and visualize the end of the catheter in the vessel. We're in.
Okay. So, why are we here? So that procedure is pretty neat. As you can tell, it doesn't take long. So you may be here for the same reasons I was attracted to the skill. So we take care of patients in their most acute and vulnerable times. We want to do better for our patients, but in an emerge, we do it in a pressure cooker. So having great skills and knowledge is paramount to providing great care in the emergency department. IV access is a common skill performed by nursing staff, and difficult IV access patients make up approximately 25% of our patients in a day. So leading to delay in access, multiple IV attempts, and it also has that butterfly effect on the rest of the patients in the emergency department. So having a few tricks up our sleeves is why we are going to discuss this today. And so as it says on the slide, we want to give our patients great, amazing care. We want to poke them less. We want reliable IV starts and get them their treatment faster. So during this presentation, I hope to offer you some information about point of care ultrasound IV insertions and a way to offer this skill to nurses in your ED. So for those of you that have started implementing in your department, I hope that you can take a few pearls from what we've done and move it forward. And for those who are just starting out, my hope is that by the end of this presentation, you can take some lessons from my experience and help you get started. So I'll speak about the process and implementation that are required to get the program started, as well as what the literature says. I'll speak to you about collaboration, engagement of the nurses, and about hospital resources. I'm also an ED nurse, so I'm practical to the bone. So I'll also be showing you the technicalities of the procedure, the strategies and tools I use to teach my program, and what you'll need to implement ultrasound-guided IV in your ED. So I'm going to just put a few of these up just for reflection. Unfortunately, because we're not in a real classroom, we can't banter back and forth, but feel free to, add your reflections in the comments bar or Q&A. So where did this come about? Ultrasound-guided peripheral IV was first described in 1978. And then it was the first it was used then. And the first study actually done on this technique was done in 1999, and it compared ultrasound-guided technique versus standard technique. And then in 2004 was the first known nurse-led ultrasound-guided vascular program that was implemented at a level 1 trauma center in Texas. So you may be thinking, this seems neat, but what utility does this have when I'm in an emergency situation? And really the answer, this is not useful in an emergency situation that when patients require immediate access. So if you couldn't find a vein using IV, then you would have to move to IO, which would be the preferred choice. So just so you know, it can take up to 7 minutes in a practiced nurse to get IV under point of care ultrasound. However, it is a very helpful tool for the cases listed above on this slide. These are called difficult intravenous access patients, so DIVA patients, which was described in a lot of the research. So on the screen, you might also see there's a black and white little checklist. So this is the DIVA tool that we use in our ED. Our nurses have them on our lanyards. And it was developed so they could kind of decide really quickly who needed ultrasound-guided IV. So the other thing to note is what your nursing college says about using point-of-care ultrasound. So point-of-care ultrasound is considered advanced practice skill, which requires development through education, attending focus training workshops, preceptorship, and clinical practice. So the use of ultrasound may vary by province or state and your nursing college standards. So for most nursing bodies that I looked into developing this presentation, I noted that most places, most colleges say that nurses can use ultrasound for the purpose of an assessment and not for diagnosis. So moving forward, I would recommend finding out what your provincial, state, and college recommends for the application of ultrasound energy in IV access. And then we want to know why it matters. So I'm going to offer you a little bit more about my story. So while the thought of offering this advanced skill to ED nurses is exciting, when this happened to me, due to lots of completing priorities in the ED, I had to wrap my head around whether it is worth pursuing. So I questioned how difficult it could be. So I learned the skill first. So at the time, our hospital CT technologist started doing ultrasound-guided IV in the CT suite. So the lead CT technologist, Corey, generously invited me and the ED doctor, Dr. Mary Cameron, to come learn ultrasound-guided PIV in the ultrasound suite. So I was the test learner, spending a day putting IVs under ultrasound, and the CT technologist helped me learn the skill. So while we were in CT, I learned a few things that I got buy-in for doing this skill. So one is that the patients who often had many IV sticks in the past were relieved to be only poked once. They also expressed being more cared for because we were trying something new. Even as a new learner, when I was there, most starts were successful after the first little while trying, and that resulted in using less equipment. And by the end of my training day, I really felt a sense of pride that I had learned this new skill and I was helping patients that had difficult access feel better and only one poke. So that was all great. Additionally, our CT technologist, Corey, said that before implementing ultrasound-guided PIV in the CT suite, they would often send people home because they needed an IV for the CT scan, didn't get it. So once they implemented ultrasound-guided PIV, they reduced these cancellations to nil. So I was really decided that the skill was worth sharing. So the ED doctor was happy to also help me develop some training for the ED nurses to get started. So I realize my anecdotal stories are very nice, but it turns out that the literature supports these notions. So I'd like to review what papers were helpful to the development of my implementation. Because there isn't a huge body of literature on this skill in the emergency setting, I'm going to use the following studies on this slide to break down the data and support the use of POCUS in ED. So there were some common themes that I'm going to review with you, and they're helpful for building a case of why this skill matters and why it would be valuable for your ED. So the first trend was the benefits to the patient. So it's first good to understand what the problems were. So there's several different problems with your DIVA patient, so difficult IV access patient. So they can make up, as I said in the beginning, up to 25% of your patients in a day. And these patients end up having longer stays in ED, delays in care, multiple IV attempts that cause them pain. And it's also estimated that there's a 5-minute delay per PIV from the same provider. And then if you have to get another nurse in to try the IV as well, that creates another 15-minute delay. So you can see how a procedure that would be only 2 to 5 minutes can really get longer and longer and longer. This also contributes to the backlog in ED. So what is the benefit to the patient is that once a nurse becomes proficient at ultrasound-guided IV, they have a 95% success rate on the first attempt. So as I said, when they're more proficient, it takes about 7 minutes to perform an IV. They have increased patient satisfaction with their care, decreased wait times, and faster time to IV therapy. So in the same, there's also efficiency of resources. So this is the second trend. As we know, it takes longer to get an IV in a DIVA patient. So one study said it takes twice as long to get an IV, resulting in longer length of stay in the ED, sometimes even a longer length of stay in the hospital. So the benefit of POCUS is as follows. So supplies are reduced. You're not using as many IVs to poke. The time, reducing length of stay in the ED, in the hospital, and improving flow. And then for personnel, so it's only one nurse coming to start that IV, and there's no need to call in for extra help. So as a bonus kind of data, in a study by Gosselin et al., a nurse-based ultrasound-guided PIV program that was conducted over 3 years saved a net amount of up to $600,000 just by avoiding PIC lines in difficult access patients. And of course, there's also benefit to the nurse. So the problem when nurses miss the IV is that sometimes the perception from the patient is that they're not technically competent. It's not necessarily the case, but they kind of lose confidence in that nurse. So for the nurse, their technical competence goes up. They can establish that IV quicker. The patient perceives that the nurse has great skills, and they can also have the ability to access non-palpable veins that you just can't find without ultrasound. There's also a few more commonalities in the literature that I want to address. So one is that these studies were conducted in big centers or teaching hospitals. And the other is that there was a dedicated project or formal quality improvement projects associated with the study. So it's, you know, I want to just address that this may not apply to the reality of our hospitals on this webinar today. So for myself, being a small hospital, I don't have as many resources. So what I can provide you next is a bit more of a grassroots approach to implementation. So unlike large centers in the studies presented, which were provided with resources to implement their education, I pursued POCUS in a smaller city hospital where resources are scarce. So I leveraged some of my, some of what we already had in our hospital to help nudge my program forward. So really, I think that emergency departments, both large and small, can utilize this skill to benefit their population. So how would this benefit your environment? This is a little reflection for you. So if you're still here, then you're interested in taking this on. So is your organization ready for this? Let's talk a little bit about that. The first thing we want to consider are your resources. So those people you can collaborate with, support from inside and outside the organization, your time and your budget. So let's break that down a little bit. The Guelph program is progressing forward and it's because of many gracious contributors to the initial stages of the implementation. So all the collaborators that I'll present next came at the right time, some serendipitously, and helped kickstart my implementation. And it's been moving forward faster than I thought it could. So for those starting out, the strength in your education is going to be finding those people you can collaborate to drive it forward, and in the way of knowledge, skill, influence, support, and resources. So who are those people? So for me, these are my people that I collaborated with. So I'll break down who is part of my implementation and why. So the first one is the ED physician, Dr. Mary Cameron, that collaborated with me and really gifted me the training. She had trained most of our physicians on point of care ultrasound in the ED, and now is extending that learning to the nurses. So for which I'm very grateful, and she gave me a great starting point. She developed the training by watching how I learned in the CT suite and developed an in-class training program. So for you, you'll need to find an ED physician to support you and the nurses. They may not give you the starting point, but having someone to also advocate in the department can be helpful and supportive to the brave nurses that dare to try the skill in the ED. The next one is so someone who knows the skill. So for me, this was the CT technologist, Corey, who I sought out to help me learn the skill. So his experience was beneficial to the learning the skill, troubleshooting new problems for the nurses. And now I actually send some of my nurses that I train to the CT suite in this nice controlled environment when he's there. And so he can mentor and help with the learning as well. So finding a person in or department that can help you, with their experience will be valuable to your program. The next is a clinical educator. So that's me in this case, but as I see it, this could be a clinical educator, a physician, a resource nurse, a resident, or a clinical lead. So this is the person that's going to drive the training forward. So the commitment to the implementation requires time, perseverance, and getting creative with resources. The directors of care, of course, you need support from the administrators. So for me, while there's no additional funds for the nurses to be paid to get trained, the ED director, as well as our director of professional practice in our hospital, are supportive of the time that I've put into training the staff. And this one, if you have students around, they're wonderful resources. So I was really spoiled when I took on a master's student for a semester. She was also an ED nurse too. So of all the projects I offered her, she chose the ultrasound-guided PIV project. And so not only did she volunteer to be one of the first learners, she also did a deeper dive into the literature, which informed practice and refined the program. She also developed 3 tools to be used by the learners. So one is a DIVA tool, so a difficult IV access tool. 2 is a checklist for insertion, and then 3 is a cannulation record. The other serendipitous thing that happened to me is that in the first year of starting point of care ultrasound education, the hospital bought new ultrasound units for the ED. So through this, I met Kristen and Carol, who have been a big support in offering resources to run the courses, some extra technical knowledge about the ultrasound units, and real vested interest in the success of the program. So they've since helped me improve the program by providing extra resources like e-learning that I now get the participants to complete before the in-class portion, which made my in-class portion shorter, which is really nice for the nurses. And finally, for the program to get traction and for the skill to be used in the ED, you need to find those nurses that dare to try something new. So the best nurses for this role have a few targeted qualities. So they're those informal leaders, they're the influencers in the department, they're skilled and they crave innovation. So these are those natural leaders in the clinical setting. And because of their, great knowledge and skill, people trust and respect their decisions. And, they want to often follow their viewpoints and actions. So finding your trailblazers and putting some energy into their training and experience with the ultrasound-guided PIV will be the cornerstone in moving your program forward. As those, as they come in and start doing the skill, those passive observers will eventually be interested in the skill as well, and eventually they won't want to just call somebody else for help. They'll want to do the skill and be the one that saves the day. The other thing to consider when you're getting started is time. So that you'll need time to develop your program and your curriculum. And if you're the person who is going to be teaching, I would also take some time to learn the skill yourself. Once you have your curriculum and practice established, keep the momentum. For me, a 4 to 5 hour commitment every few months will start to establish a base of nurses that can do the skill. And in terms of your curriculum, know that there are more resources out there. So when I started out, I didn't know about all the resources, so I did have to take time to develop curriculum. And the initial trailblazers that sign up for the first few courses will need a bit more time and support in the ED. This responsibility can also go to your collaborators like your ED physician or your POCUS expert. And then finally, there's time commitment from the learner. So we'll talk about that because less is more. And then there's budget. Eek. So for me, this is practically non-existent. So when I presented this project to the director of the ED, she was absolutely intrigued, but unfortunately there was no extra budget to pay the ED nurses to do the training or for any materials. So we did not buy an ultrasound unit for training. We didn't have fancy phantom veins. So this is really part of the whole deal. You need to get creative. So I'll discuss that in the challenges. So just as a little reflection, what resources can you draw from? So let's talk about the challenges. So the first challenge is the no budget challenge. So we talked about that just a moment ago. So for me, we couldn't pay our nurses to attend and there was no budget for fancy vein models. So I had to get creative. So how did I deal with that? One is that our ED physician, Dr. Mary Cameron, donated her time to get things going and passed the baton to me, which was really great. And for the implementation, my role as educator would be classified as in-kind funding. So my labor as an educator during work hours requires me to kind of work this into my regular work flow and what I do on a regular basis. The other in-kind funding that you can look to is your clinical expert. So currently, our CT technologist, Corey, when he is working, I will send the nurses to the CT suite to be trained there because it's a nice controlled environment, and we do have a lot of difficult access patients there. For the course, we don't have a special unit just for training, so we do take one of the two units off the ED floor for the time being. So that means that sometimes, you know, if they need it suddenly, we may have to interrupt the course to run it back if needed. The other thing I've done is kept the courses short, so not taking too much of the learner's time. So for the trailblazers that have joined my courses, they've done so out of the just passion for learning. And so I just wanted to keep it short and sweet. When I first started, it was half a day long, and now I've reduced it down to 3 hours. And I have our nurses interested because it's more doable to do 3 hours rather than a half a day. The next challenge is if I can't get the IV, then no one can challenge. So this is a very common one in ED because ED nurses have these skills. So, you know, if there's any ED nurses out there, can you think of a time when, you know, you had this very sick patient, maybe they're in DKA, they have a history of IV drug use, they're edematous, and on top of all, they're on a blood thinner. So after several attempts by your colleagues, you know, somebody gets that 24 in the thumb, and, you know, life is great again because you have a little bit of access. But so why would I need an ultrasound machine to do that, right? So how do we deal with that? So I rely on my nurse trailblazers or the influencers. They're my biggest focus because when they get good at this skill, they put the energy and time into doing IVs under ultrasound. And so when it comes time to, you know, see one of these patients that has difficult access and everybody else has tried, they can sneak in there and get a bigger IV than that little 24 in the thumb. So really target those who are interested first for your training, and then others will follow naturally. So the DKA patient I just described a slide earlier is actually a real case just a few weeks ago, is that my trailblazing nurse came in after the fact when, you know, all the nurses had tried. They say, oh, come try this. And, you know, they had the little 24, but she was able to get a nice 18 in a non-palpable vein. And the patient did well. So the other thing to consider is the climate of ED challenge. So realizing there's seasons of change in the ED and what's happening at the time. The staff, the culture, everyone's time, ups and downs. So how do we deal with this? All ideas. So, you know, the skill takes time to develop. So those bold risk takers need that time to actually get in there and try the skill. So in ED, we all know the ebbs and flows that comes with the season. So staff turnovers, full moons, now pandemics, right? So good planning is essential. We all know best laid plans can fail. So while you might want to get this going, you know, when energy is low and volumes are high, too many new projects, you know, engagement can be very difficult. So for me, I positioned a lot of my courses in downtimes for my organization. And I have a good sense of when we're doing lots of projects in the organization because I am part of professional practice. But for example, I try to avoid September altogether because it's the back to school rush. Mid-December, I don't usually do anything for this kind of thing because of winter holidays and people are relaxed at that time. And my classes are also very small, so I can accommodate a date and time that works for those nurses. So classes are really, 4 to 5 to 6 people. So know that all of these challenges can be overcome. So despite lack of budget, paid train time, and now a pandemic, guess what I didn't do for many months? IV courses. I've now successfully run 5 courses over the last couple of years and have 28 nurses out of my 100 nurses trained on ultrasound-guided PIV. So I also have a waiting list of 12 more nurses that want to take the course this upcoming year. So I'm going to put this out to you. What challenges might you have? Those were my challenges, but maybe you can think of some that right off the top that you may run into. So let's get into the practical stuff, which is my favorite stuff. So implementation in your ED. So this is one of my classrooms on this picture. You can see that is pretty simple. So you have to consider your timeline. We talked about time before. So we've already talked about collaborating with your internal people and getting buy-in. And then you want to do your curriculum development. You want to get teaching. So for me, I teach a course. I try to teach a course every 3 months, except for when there's pandemics. And then from those courses, I try to get 1 to 2 super users or champions that can help out in the department with new learners. So my curriculum is pretty simple. So I do an hour of e-learning before class, and that was provided to me by Sonosite. So this is why I suggest reaching out to your ultrasound representative, because they may have a resource like that for you. And then I have a 3-hour in-class education where we do hands-on training on phantom veins. And then from there, I do 3 to 5 supervised cannulations with the learner on patients. So that can be with me, it can be with the CT technologist or the ED physician, or now, because I have so many super users, there's other nurses that can help with these initial cannulations as well. I do ask them to target 20 cannulations before they start helping others, so before they are considered a super user. And then I do recommend them trying at least 10 starts per month, just to keep the skill going. So you might be saying, like, why 20? So in a study by Moore in 2013 that I presented earlier, it was determined that after 10 successful IV attempts, IV cannulations, nurses had an 80% success rate on the first attempt. So that's really great. But after 20 attempts, that rate increased to greater than 91% success rate on the first attempt when using ultrasound-guided PIV. There's a few learning objectives in my course, and they're very simple and to the point. So short and sweet is I want them to be able to identify those DIVA patients and start to use ultrasound as your first choice instead of trying a couple POCUS and then going to that. The second is just successfully inserting IVs under point of care ultrasound, following the procedure that I to them. I do like them to report on their cannulations and troubleshoot through different cases. And then the last objective is to help new learners. So I actually have a little informal contract with all the learners that come in that, at the end of this, the expectation is that you will become a super user and help the new learners going forward. So I said I'd had a 3-hour in-class course. So this is how I break it down. So many nurses, especially ER nurses, love and you know, love to learn and love hands-on experience. So give them lots of playtime. So in the hands-on course, I will spend 5 to 10 minutes on a concept and then 20 to 30 minutes practicing the skill that was presented. So this is the skill. A few pearls to help them build their skill. One is just practice, practice, practice. And first I ask them to practice with the ultrasound probe before they start cannulating. And then once they get used to it, is to use it on easy people first. So my target person for my new learners is that, you know, they look for people who are maybe well hydrated, but just have really deep veins. So, you know, we're aiming for that 1/2 centimeter deep vein, and that has a diameter of at least 1/2 centimeter. So those are the most successful first attempts. Once they get those, then they start to pick up steam. So I'm going to show you a few videos. So the first thing we teach them is IV, or trying to find a vein in short axis. So if you look at this video, you can see that she's holding the probe in a perpendicular to the vein. And what we get is this little black dot. And so that's the vein or vessel. And that's what I get them to look for. The next skill is distinguishing whether there's a vein or artery. So you get to see way more underneath the skin with an ultrasound probe. And so it's a wonder, you know, out of the thousands of IVs that I've put in, that I've never got an artery, because a lot of them run right beside each other. So their second skill that they learn is distinguishing a vein from an artery. So here you can see when she pushes on the probe, one little dot squishes down and the other one stays circular. And so veins are much more compressible, and that's how we can distinguish between a vein and an artery. And then the other view that we like to practice is long axis. So this is a really great one. So you can see she's holding the probe along the length of the vein. So in the middle of the screen, you'll see this nice black line. And so this is a nice shot for when, once we get the IV in, you can thread the cannula in and actually see the cannula between the in the vein, and you can actually see the flush too. So I'll show you the whole procedure here. If I can get this working. Sorry about that, just a moment.
Yeah, Lisa, I just looked. I don't have that video, so.
Okay, I might have to. Sorry about that.
They worked yesterday.
Oh, here we go. Okay, we're back on track here. Hopefully everybody can see it. This is a phantom vein. So you can see the black dot in the middle of the screen. And what's happening is she's using the probe to find the vein. So we're looking in short and long axis. And then what she's going to do is there's like a center line in the middle of the video as well as in the middle of your probe. So that's where we aim the IV. And so from here, she's just going to walk the IV down towards the vein. You should start to see a little white dot now just above that black dot, and that's the IV tip. So once she gets it right over the vein, she pops it into the vein, and now you can see it's like a target. in long access, we can see it become cannulated. So she's going to start to advance the IV and also still check that it's right in the middle of the vein. So that's the value of the short access, is that we can see that it's right in the lumen of the vein, versus long access, we can see the catheter come through. So that was a nice little model that we saw in the last video. If you don't have these models yet and you want to get started, my suggestion is using chicken and gelatin. So this is what I've been using for my first few courses. I've still since kind of borrowed a few items to help, but I find chicken models work well. They look like tissue, and so I just cannulate them with some animal balloons. Seems silly, but it works. So you might be thinking, you know, what's the same here? You have this extra piece of equipment. So you're still using your regular IV equipment, maybe a longer cannula, but otherwise it's all the same stuff. You're using a tourniquet, and once the IV is accessed, you're still using IV skills. So once you get flashback, you can drop the probe and then just do IV skills. So what is different is that there's no palpation of the vein. So this is a really weird sensation for a nurse that is so reliant on palpation. I'm one of those people. There's a change in workflow. So you have to ensure that your ergonomics are correct when you have the screen and the patient in front of you, because any little movement in your body can create big movements inside next to their vein with the angio. Visualization of the vein. So there's so many different new structures that you'd never even knew existed under the skin. Well, you knew they existed, but you get to see. And that's a really interesting thing to see, because you can even see a hematoma develop when you kind of nick the vein, and the vein will shrink and then be pushed away from where you had originally started. The angle of insertion changes as well. Because these are deeper veins, the steeper the angle for the IV, it creates more successful attempts. And then the hand-eye coordination, of course, is a big difference for nurses, who, especially those who haven't used this skill before. So I just anecdotally, the nurses that come into my courses that play video games catch on to this very quickly. I was one of the ones, I don't play video games. The hand-eye coordination was really difficult. So there's a few tools you can use to increase the success for your learner. So there's the ultrasound-guided PIV checklist. There's that DIVA tool that I showed you, where you can actually score if they're a DIVA or not, and whether you should just move to ultrasound or give it a try by standard method. Cannulation records, so collecting data and troubleshooting with your learners, what went well, what went wrong. E-learning, so because my learners have e-learning, they can reference back to it. And then based on your college standards or organization, you might need a policy procedure. And then, of course, it's always good to discuss the pitfalls. So this is, you know, the more successful and less frustrated nurses are by their new skill, the more often they'll use it and build more confidence, and the better they'll get. So there are a few pitfalls to be aware of in training. So one is, don't let them try cannulating a patient on the first day after the course. So if they miss, they will feel bad and shy away from trying it again. So I have a couple people that this happened to. So have them stick to the plan that you've put out for them, and just, you know, get them to simply scan their, you know, colleagues in the middle of the night, or get them used to using the ultrasound machine first. Don't let them go it alone for the first few times. So ensure that there's clinical support available in their first attempts, because if they get frustrated, then somebody can take over. Encourage them to follow the steps in the training exactly before adding their own flair to the skill. So in my experience, if they don't start with all of the steps and then try to skip a few, they wind up unsuccessful and frustrated. The other is just, I'd suggest playing Nintendo. So the most difficult part for the nurses learning this is the hand-eye coordination. And as I said, nurses who already play video games are actually really good at picking up the ultrasound skills. The other thing is ergonomics and body position when setting up. If they do this properly, they will move their head and then they will be unsuccessful in their IV attempts because it moves the needle inside the body. And last is simply not using the skill. So if they go off and they don't try the skill, don't try to scan, or don't try to start to cannulate, then sometimes they just don't end up using it. And there are a couple of people that I have that ended up in this position. So sustaining it and driving it forward. So for myself, I have a few next steps for my program that I'd like to offer you. So for me, I really want most of my ED nurses to learn the skill in the department. So this will take time. As you know, I only run the course a few times a year, and I only do, a dozen people at a time. But before, I get a full complement of ED nurses using the skill, I also want all ED nurses to identify DIVA patients and that ultrasound be the first choice in starting that IV rather than poking them a few times and then calling that super user to come and put in the IV under ultrasound. The other thing I really want to do is collect data to help that validate its utility. Often data does tell a story. And then spread the skill to other units. So I also have done a course for a few ICU nurses who are now using it, but I would like to spread that to ICU and other floors too. I think this would actually be very valuable on a medical floor where you do have a lot of DIVA patients. So I hope that through this talk, you've attained a better understanding about the benefits of ultrasound-guided PIV, and also can think of some strategies to get this going and leverage some resources in your own organization. I hope that some of the strategies and tools that I've provided you will help with your implementation going forward. So we all strive to give amazing care to our patients. And I hope in the future, adding this additional skill will enhance the care that it's already in place in all of our emergency departments. So that's all I have to offer you today. So thank you for listening. I think the next stage is doing some questions.
Hey, Lisa. So yeah, we do have quite an interest in having some questions answered by you, which is great. Okay. So there were, given the demonstration videos that were shown, there were quite a few questions about what about gloves and probe covers, so I can understand in this current environment. So gloves, probe covers, sterile gel, those kinds of things. So comments on that.
Yeah, no, that's a great question. So you could see in our pictures, obviously we're using chicken, so there's a risk of salmon, but so we definitely needed gloves. But yes, we do use all of our PPE that we regularly do. But for the probe covers, there's a couple of ways you can do this. So one of the strategies we use is just a sterile glove that we put over the probe with an elastic. You have to put some of the ultrasound gel just between the glove and the probe, so then you get a good view. The other one, and I don't know if it's been validated for sure, is using a Tegaderm over the probe in order to keep it clean. And I'm sure there's also just sterile probe covers that you can use as well.
Excellent. What about sterile gel?
Yeah, so we ordered a bunch of sterile gel for starts, but we also just use the best method for getting contact is just sterile saline. So that's more accessible in the ED and easy to find. So we often just use saline instead of gel. The other benefit to using saline is it dries up quickly. So then once you put your IV in, you don't have to clean off the gel around the cannula in order to put your Tegaderm on and secure it.
Excellent. There's also a question around how did the ultrasound-guided IVs fare in terms of dwell times and complications? Any differences?
You know what? I don't have the data on that. I do know that I've done a few on patients that had, you know, like a cellulitis that had to go home with the IV and then come back. They did fare well. In terms of like going up to get admitted, I actually don't know how it progressed after they left the ED. And that's why I say, you know, more data is required for our program.
Okay, also just a comparison question. Do you know whether there's evidence of the success rate with ultrasound guided versus using a vein finder?
That's a great question. I do not. I've never compared a vein finder to ultrasound. So hopefully somebody out there, I haven't come across it in the literature, and to tell you the truth, I haven't looked into it. So, and my student never found anything about it either.
Okay. So you mentioned the 7 minutes approximately, you know, once someone is trained and competent, 7 minutes to get the IV in. Does that include limb assessment?
Does that include limb assessment, did you say?
Yeah, yeah.
I don't know specifically. Sorry, I'm not giving a lot of good answers here. No, that's set up, yeah, assessment, yeah, assessment with the probe, like looking around for the vein. Is that?
That's what I'm assuming.
Yeah.
Yeah, doing a little bit.
Yes, yeah. I think from start to finish, setting up your ultrasound machine to actually getting the cannulation is 7 minutes.
Okay. Got it. Okay, another one. So another one relates to standards of practice. Do you have a like sort of a guidance around applying standards of practice for vascular access to the skill of ultrasound guided PIV? Like, how do you bring those two together?
Right. So I did look at the International Nursing Society for, like all of the standards of practice around IV access. I did look at CNO standards so CNO being the College of Nurses of Ontario standards. But in our organization, we do have, based on all of the evidence, we have our own standard of practice. So it's a policy procedure that I've included this particular skill into.
Okay, right. So basically the conclusion is that all of the standards of practice apply, and you're simply just adding a tool with some guidelines within your institution?
Yes, sorry, yeah, exactly. So all of those standards that you would usually use for a standard IV insertion are all the same. It's really just the assessment with the ultrasound probe and utilizing that probe to visualize the cannula going in.
Got it. There's a question on tourniquets. Someone is saying that they understand tourniquets are not recommended with ultrasound. Your thoughts on that?
Hi, Carol, are you still there?
I'm still here, and you froze on me as well. So let's try that again.
Oh, okay.
There's a comment about someone understanding that tourniquets are not recommended with ultrasound. Do you have thoughts on that?
Yeah, so there's two trains of thoughts on that. Is that, you know, you're just visualizing the IV, the vein anyway under ultrasound, and some people do not use tourniquets in this procedure. I find there is more success with a tourniquet because it does increase the size of the vessel, and so then therefore you can see it better, or the diameter is bigger on the ultrasound screen. I was taught by our CT technologist to use a tourniquet, so that's been my practice.
Okay. Like I said, a lot of questions. This is really good. How did you address infusion practice via ultrasound-guided PIV, such as it not being suitable for vesicants? Did you create a policy for this?
I did not, but you know, I think this would be valuable in those particular situations because you can get access to, say, the basilic vein or bigger veins that aren't palpable, and you can get bigger IVs sometimes. It would be more valuable in those instances to get it under ultrasound rather than trying to get a tiny vein IV somewhere else.
Right. There were some questions around catheter length, because quite often the DIVA patients are obese patients. What are your thoughts on catheter length selection?
Yeah, so we actually did end up getting longer catheters. I'm trying to pull the length out of my head right now because of that purpose. One, you go steeper into the vein than we do with standard technique, but if it's deeper than like a centimeter on the ultrasound, then you do need a longer angio as well. So we did purchase a few longer angios to be able to do this, and our CT suite also has those items available, so sometimes we trade back and forth. They have the 22 long and we have the 20 long, so based on how deep the vein is, especially in that obese patient, you may need a longer angio.
Okay,
that's a good question.
Question on the e-learning. Question is, how do I get the e-learnings set up for my nurses?
So I would recommend reaching out to your ultrasound representative. So for me, Carol and Kristen just provided me with the Sonosite e-learning. And it is just simply a web link that they have a code to get in, and they e-learning at home just over regular internet.
All right. So I think we've got a lot more questions to get, that'll take us well past our 12 o'clock. Laura, what do you recommend? Do we do a couple more?
What I was just about to say is I will capture all of these questions that we still have open, and we can work on creating some answers and then reach out to the attendees with those answers, just out of respect for everybody's time. I know it's after the hour. So I did see a lot of people ask about a recording of this session, and we will be posting that on the page that you see here on the screen, the secure.sonosite.com behind the scan webinar. That will be posted within the next 24 hours. But yes, we will capture all of these questions and work to get those answers to you all. Lisa, Carol, if there's not anything else, I think we can conclude for today. Did you have anything else you wanted to say?
For me, just thank you for coming out today and being interested in this. It's valuable for your ED, and it's worth looking into. So thank you so much for listening today.
Yes, I agree. Thank you, Lisa, for an excellent presentation. That was a ton of information, and I sure learned a lot. So thank you so much for taking the time to speak with us today. And thank you all for joining us. We will conclude. And again, we'll reach out to you with questions as best we can. Thank you, everyone.
Thank you.